just this week, somebody said, Ugu sounds like it's from Star Wars. Okay. So I think there are more people here today than there were yesterday afternoon when I presented. I'm Romola Naidoo, and I'm presenting on behalf of myself and Lorna. Lorna? There's Lorna. Okay. So Lorna's my pediatric dyad. Okay. Just this slide, 2 comments that were made, and one just a week ago by a family physician in our district who asked where I'd worked previously, and when I said to him where I'd worked, and he says, well, this job's a downgrade. Okay? And the other is a comment there from one of the medical managers at one of the district hospitals in our district, and he said to me, Dr. Naidoo, pediatrics is not the only discipline I have to sort in this institution, which actually means I'm doing my job relatively well. Okay. So what was the problem? And Lorna and I found that when we attended to the CHIP meetings, and we tried to attend all of them in the district, we found that the same modifiable factors were occurring again and again. And we found that we were doing too many trainings, in all honesty, and that we actually felt that, there were no gains from these trainings. At the trainings, whether it was IMCI, whether it was KINC, ETAT, it was the same attendees. And it was quite obvious that they weren't cascading what we were training them, or what they were meant to be learning, and that at the facilities, the same practices that had been practiced were continuing. So these trainings were not making a difference. And we realized that we had to improve and update the skills and knowledge of the healthcare workers in the district that are not in academic institutions. There's one regional facility where they have academic meetings, and the other 3 district hospitals aren't academic. Okay, and so our target group was essentially the healthcare workers in district hospitals and CHCs, and I've got there a couple of dots, and PHCs. Okay, our target group was, I want to emphasize, doctors, both old and young. Okay, the former are a bit difficult to teach, and nurses as well. So we decided to do modular teaching, and this is a bit in the incorrect order. I think we placed more emphasis, and rightly so, on the gaps and weaknesses that we identified at the CHIP meetings. And we took these long trainings, the KINC, ETAT, HBB, IMAM, and IMCI, and broke them into shorter sessions. And we decided to do these trainings in modular form on site. So they're 1 to 2 hour training sessions, which doesn't mean we have the rest of the day off, because we would do them in small groups. So you have between 6 and 8, sometimes 5 to 6 staff attending the training in one session, and then you have the next group. It is interactive, and there is a slight didactic component where one of us has to stand in the front and do a bit of a lecture. Okay, but it also included practical demonstrations and skill sessions with procedures. And these were the procedures that we found were problematic. So it was intraosseous lines, umbilical lines, and I think our very first modular training on site was intubation, because there was a baby with meconium aspiration that demised because the medical officer on call at the district hospital couldn't intubate. Okay, so I've given you examples of topics. It isn't all practical, but it's other things that we find they just don't know. And when you're at the CHIP meeting and you find they don't know how to manage a high sodium and you say it, there are probably 6 doctors at the meeting, but they don't go back and tell the doctors who are post-call or the doctors who are on leave. So those are some of the other topics that we dealt with: shock, hypernatremia. Okay. We did the training in small groups, and we tried as far as possible to do a follow-up where, you could assess how much they knew, not formal testing, but, and then you actually repeated the training, and you did find it was much easier the second time round. Okay, so the new practice or idea was taking the teaching to the healthcare worker and management of these district facilities. Strangely, they're very receptive. Despite that comment I put on the first slide, management in all the district hospitals, as in the medical managers, attended these trainings. And I think that the whole plus for me was that there's minimal disruption to service delivery versus 3-day trainings. So if you have a 3-day ETAT or IMCI is not 3 days, it's 11. But if you have a 2.5 or 3 day training, the facility will send one doctor. Whereas here on one day, when we did intubation, we actually sorted 26 doctors. And that was not, that was besides the nurses. Okay, and the other advantage is that it's small groups, it's comfortable, it's interactive, they ask questions. Although I will get to this at some point, is that you find the doctors are reluctant to ask questions in the presence of nurses. Okay, and when you're doing this training, you actually identify more of their weaknesses. Okay, the people that were trained, the doctors and nurses, were actually very enthusiastic about it. And at these sessions, they would identify own topics that they wanted to know more about. Okay, what was difficult was the older doctors, and in terms of our time management. So in terms of upscaling, yes. We actually don't need extra staff to do this, but if we, as the DCST members, had to attend fewer meetings, it would be very good. Okay, we attend all sorts of irrelevant meetings. The trainer needs to be updated, so I can't go and teach something that I don't know the latest about. Okay, night staff has been a problem, and we've really tried to work around this, where we tell the facilities we're training at least one person in night staff during a day session, and can they cascade the training? We've also done some training sessions rather early in the morning at 7, so the night staff can attend before they go off. If we had to upscale, we definitely need better equipment. Okay, we have our family physician, Dr. Tom, who's constantly putting broken heads together and attaching limbs so that we can use these very old mannequins that we have. IT is a real problem. Okay, so the results, and in the words of one of the specialists at the regional hospital, she says, finally the district hospitals are talking the same language, and this is when they discuss cases telephonically. At the CHIP meetings, we find that the gaps are not recurring, and that they've actually managed their cases exceptionally well. And in the last 3 months at the CHIP meetings at the district hospitals, we find that the modifiable factors are now pre-hospital. So it's at the PHC level or in the community, and that's definitely work to be done. When we do support visits and ward rounds, we find that the new practices that we've spoken about are actually in place, and it's forged closer relationships with the district team. Implications, obviously a decrease in mortality and morbidity rates. We're finding that with their mortality, invariably, they would have 2 deaths a month, and one would have hospital modifiable factors, and that's no longer the case. Decreasing the number of ICU transfers, and obviously improving the quality of ICU transfers. It's cost cutting. We don't have to have these expensive trainings. And then a very big advantage is sound pediatric practice to the entire medical component of the district hospital, not just the doctors that work in pediatrics. Okay, the challenges, as I said, are the number of meetings we have to attend, long-term sustainability of this. We find ownership of trainings at district facilities a huge problem, where people there that are trained are reluctant to train themselves. And for those of you that are at the medical schools here, it just, we're wondering about the undergraduate and nursing curriculum. Okay, attrition of staff is a challenge. You've trained staff and they've gone off elsewhere, which means you have to do this constantly. I've never been taught how to teach adults. It is difficult, okay? And I think the last challenge we find is in terms of governance. Everything about DCST, you always hear this word governance, but if we don't get the resources, as in the staff and the equipment at the facility, you can preach governance till you're blue in the face, okay? What we would have done differently was, I don't feel comfortable training nurses and doctors separately. You're just creating these borders and boundaries. I think we should rather spend more emphasis or more time training on problems identified compared to common conditions. We should email the theory prior, and we didn't do baseline or pre-tests before these trainings. I think it's very important, just as medical practitioners, we have a CPD audit, that we put these skills as requirements, and that practitioners get tested on them. And the classic example is one doctor who couldn't intubate, a senior doctor, and we went over it, but we need to have some mechanism in place to make sure that people have these life-saving skills. Thank you.